Yeah, I'm gonna. So everybody, I've got the animation cooked up. I'm gonna do that first because we didn't play it last time. That'll summarize really everything you need to know. The only thing I knew they did it for convenience. When you do the animation, you're talking about rhinovirus, and really that's a cold virus that never goes inside the cell, but they're using it for the ease of and so I always prefer. I know they're doing it. It's a good animation, but they really should have picked another thing for that because it really takes away from the quality of it. I think just a smidge. I mean, it's my instinct to be picky, and I'll go back and sort of summarize this and move on. And it's an interesting topic because I'm going to try to. I don't want to gloss over it, but I do want to because a lot of you have chosen variations of immunological disorders to present. So I think we need sort of a collective chat about that, if you will. So we'll listen here.
This patient's cold is caused by rhinoviruses, shown here in red, that entered her nasal passages and escaped the first-line innate defenses such as mucus and cilia. Some of these rhinoviruses entered the respiratory epithelial cells where they replicate, releasing more rhinoviruses into the patient's nasal passages and tissue fluids. In the tissue fluids, cells of the second line of innate defense, such as this dendritic cell, carry out surveillance for anything that appears foreign. Dendritic cells engulf the rhinovirus within an endosome. The endosome fuses with a lysosome, whose enzymes digest the rhinovirus. The resulting rhinovirus fragments are called epitopes. The dendritic cell then attaches the rhinovirus epitopes to presentation molecules called MHC2. This complex folds outward so that it sits on the outside of the dendritic cell membrane. The dendritic cell then enters a lymphatic vessel and travels to a nearby lymph node. Here, the dendritic cell, part of the innate defenses, encounters a helper T cell, which is part of the adaptive defenses. The T cell receptor, or TCR, of this helper T cell recognizes the rhinovirus epitope, while the CD4 glycoprotein associated with the TCR recognizes the MHC2. The dendritic cell then stimulates activation of this helper T cell. Adaptive defenses help to control the current infection, but also provide immunity against future infections by the same rhinovirus. They are carried out by two types of lymphocytes, B cells and T cells. Immature B cells conduct surveillance in the lymph nodes, using B cell receptors, or BCR, to recognize only one specific epitope. The BCR on the left does not recognize the rhinovirus, but the BCR on the right does, and this B cell is selected for activation in a step called clonal selection. The selected B cell takes in the rhinovirus, degrades it, and presents the rhinovirus epitope with its MHC2. Our mature helper T cell recognizes the rhinovirus epitope with its TCR and the MHC2 with its CD4. Then the helper T cell secretes chemical messengers known as cytokines that activate the B cell. The B cell proliferates and differentiates in a process called clonal expansion, resulting in two types of cell. Memory B cells carry the memory of this pathogen for many years. Plasma cells secrete antibodies that conduct surveillance for more rhinoviruses, grouping them together so they are easy targets for phagocytes. Antibodies in the blood and tissue fluids seek out free rhinoviruses. The antibodies neutralize the rhinovirus by binding to its surface molecules, thus preventing attachment to host cells. Antibodies are humoral defenses that target free pathogens.
Just good summary. This is a little bit more
But
intricate.
what about the rhinoviruses that are already inside our patient's cells? Another type of adaptive defense cell, called a cytotoxic T cell, can locate and destroy rhinovirus-infected cells. It provides cell-mediated or cellular immunity. Let's return to our patient's lymph node to see how cytotoxic T cells become activated. The T cell receptor, or TCR, of this particular cytotoxic T cell is genetically programmed to recognize the rhinovirus epitope when presented by the dendritic cell. This time, the epitope is presented differently, with an MHC1, which is recognized by a CD8.
Again, that would be just a different, that wouldn't be a rhinovirus, different
T-cell.
virus.
With the help of cytokines from a nearby helper T cell, the cytotoxic T cell is activated and clonal expansion occurs, resulting in some long-lasting memory cells ready for a subsequent exposure, and many active cytotoxic T cells, or CTLs, that leave the patient's lymph vessel to search for infected cells that present rhinovirus epitope with their MHC1. The epitope is recognized by the TCR of the cytotoxic T cell, and the MHC1 is recognized by the T cell's CD8 glycoprotein.
That's co-stimulation, basically. Two factors.
The cytotoxic T cell then secretes perforin molecules, which form channels in the infected cell's membrane.
They poke holes in the membrane with these protein
Granzyme, also from the T cell, passes through the perforin channels and activates enzymes that lead to apoptosis, the programmed death of the infected cell.
They poke holes in it, shoot stuff in it.
The cytotoxic T cell then moves on to look for another infected cell. Together, the humoral and cellular defenses are the body's third line of defense in fighting a very specific pathogen. The humoral defenses, ultimately in the form of antibodies, conduct surveillance for rhinoviruses that are outside the body cells, in the patient's tissue spaces and bloodstream. The cellular defenses, in the form of cytotoxic T cells, search for rhinovirus-infected cells, inducing apoptosis when they are found. Memory T and B cells help our patient's body to recognize and more rapidly fight the same rhinovirus should it infect her again.
And that's, I mean, I think having to think that one is very good compared to some of the others. Again, other than making that inherent error. I'm going back just, I mean, because it is difficult. It's easier to see than explain when they talk about the different roles. And we're talking about cytokines. The one you're seeing a lot now isn't listed here. It's new. I mean, it's been around, but it was identified. It's called IL-31. That's one for people with psoriasis, and they can inject, because, I mean, psoriasis is a pretty common autoimmune phenomenon. And basically, the immunology is such that it's effectively mobilizing the skin cells in a premature state to come to the surface. And I mean, it's really unpleasant. And so, but again, I don't know what the side effects are. I'm unfamiliar with it. They're trying to sell a ton of it. And if it works, great. But that's when you hear about it. So you can look all of these up. I just Googled interleukins, immune system, and you get a ton of references from that. So the helper T cell is the big player in this. Its name says it all, helps activate B and other T cells, induces T and B cells to proliferate, secrete those, so without them there's no immunological response, hence the tragedy of HIV and AIDS eventually. So the helper T cells interact directly with B cells, displaying those fragments, and that's typically where you see those in the lymph nodes. So, I mean, that's when you start to feel that. It's that now your body's starting to fight that cold. And so, I mean, they talk about different T cell and independent. We don't have to worry about that. So some B cells can be activated without them, some with one. And the ones that have that codependent or co-stimulation with the helper T cell, much more efficient. And they're just demonstrating to you the various steps, which you could scroll through. CD8 scales are maybe a little bit more because they require the helper T cell and to really change that CD8 cell efficiently And it's almost an exchange. It's almost like a little exchange of chemicals almost. So you're having an antigen presenting cell, a helper T cell, and a CD8 cell. So, I mean, the helper T cell is basically allows that to express co-stimulatory molecules. The dendritic cell activates the CD8 cell. I mean, so you're basically stimulating this to trigger this, etc. So it's much more complex when you look at it. And when you start, and maybe for some of you with these autoimmune disorders, this is where the fine distinction between this one and a variant may be somewhere in that process. It's such a complicated system. I mean, maybe for those who are going to be around next year at this time, maybe I was talking with Dr. Maurer about his immunology. And I mean, I think you'd find it interesting now, particularly with your background that's there. And so, and they respond, and again, they interact with your innate system, all of those things, because again, if something gets through, there's a problem. So these are just some of the ones you don't have to memorize. The one, I mean, aspects of cellular, defense against parasites, allergies, this bad boy. Again, this is the one that really is a very much, we call it pro-inflammatory agent. And really that's, and again, the Cosentyx that I utilized was a blocker for this. Something triggers that into inordinately fire. And really it's almost like we left the switch on and we can't shut it off. That's the problem when we start to see autoimmune disorders. There are lookalike problems, there's mismatching problems, and sometimes the system, because and imagine in your house, if you left a burner on, on a pot with something in it, you might have to do it. Hopefully not. You have a major incident. And now the cells they talked about, once they activate, they're just rollover structures, masses of them. If they roll over, they'll adhere if they're co-stimulated. And again, it's all about the alteration of that MHC1 marker and that irregular spike that's being protruding from it. So it'll be a virus infected cell, bacterial cell, parasitic cell, cancer cell, transfused, transplant. And so it doesn't matter if it's not being transplanted from you to you, you're going to have a response to it. We'll go over some of these. I mean, I'll mention them in passing, and I brought it up. There are 4 types of grafts. They may have it here in the PowerPoint. If they don't, they don't. One is called an autograft, not like a GRPAPH, AUTOGRAFT. That means you donating tissue to you. I did a ton of those, skin grafts. We would take skin from one area and I would move it to another. I would take a split thickness graft from one area and I would move it, or a full thickness graft from one area, and I move it to another area. Then, because I was trying to get coverage for an area that, because of what I had to do inside, had exposed, so I might have to lengthen something or shorten something, and you create inevitably a gap space that you can cover with skin, and if you do it carefully, it will take. And I had good success with it. You pick it from skin from a site where the scar, because you're taking like a chunk of skin, typically won't be cosmetically unacceptable or a problem functionally. So that's all. So that's an autograft. A surgeon friend of mine, orthopedic, he would do a bone graft to keep the joint. I might have told you about that, to keep the 2 bones adherent, because they would be unlikely to be unstable. He would take he'd go in and punch a little piece of the tibia out, and stick that between the fracture fragments so you get a screw in there and tighten it. Happy days. So it's an autogenous bone graft. Isografts are rare because you need to have an identical twin. And it's not something you generally keep in, most of us, I don't want to be flip about it, but most of us don't have one of those. The grafts that we see a lot of, other than that, if they're not, so those aren't going to have a vigorous response. Most of ours are called allografts. That means from the same species. Kidney donated to you, bone marrow transplantation, that kind of stuff. Liver transplant. Inevitably, you're going to have an immunological response. The whole idea is to limit the severity of it. Because a lot of times what makes the surgery unsuccessful is the immunological response. And so those folks are on a lifetime of immunosuppressants. It's just the reality of it. There's no perfect way to go about doing these things. It's just the way it works. And then lastly, what's called a xeno, Xeno graft. Xenografts are this from different species. I mean, you'd say that might go, what do you mean? We've used a lot of porcine grafts. Some species have relatively low reactivity. We were taking pieces of tendon and dense connective tissue from pigs, treating them and trying to replace ligaments in the lower extremity, ankle ligaments, knee ligaments, etc. We were using porcine heart valves for a long time. So I mean, it's not the way they're treated, and then the way that the aftercare and the immunological stuff. And this was early days for this stuff. The whole our ability to manufacture biologically compatible things has really changed over time. So, as you saw in the animation, the cytotoxic T cells deliver what they call the lethal hit. It's a contact thing. It's not secreting chemicals. It's not immobile like we saw with antibodies. They basically inactivate, tag it, and identify it along and make it easier for the macrophages to come over there and sweep it up. This is different. This is direct destruction. Most commonly, it's a lethal embrace. They adhere because of those identical markers. And at that point, you saw it in that animation. They release perforins. The perforins basically perforate, and in go these granzymes, basically like tiny lysozymal enzymes, and basically induce it to undergo apoptosis. Very significant. And they'll show you that. Here are the perforins. And so go back and look at that animation as much as you want. It's really a good idea. And this is kind of showing it to you. This is basically, here's a cancer. Cancer cells have very little identity. They look foreign. Heaven forbid you ever have to see a cancer in situ, meaning, when it's, I remember taking, not me taking it, I'm hunting with tractors. And they're pulling this thing that looks like something a bad sci-fi movie would show you, and it's growing inside this guy's gut. And I'm like, oh my goodness. What's that? And the deputy chief goes, that's cancer. It was awful. Pretty well advanced. I mean, it was a shame for this very nice man. That's not going to have a very good prognosis. So we pre-encode these. These are when you hear about natural killer cells in your they're a specialized cell that's part of your innate immunity. Okay, they recognize other signs of abnormality. They don't have that class MHC1 antibodies coding target cell, different surface markers seen on stress cells. So they use the same key mechanisms as the cytotoxic T cell. Okay, they prowl around the body looking for markers they don't recognize. They're sort of pre-programmed. Again, it's the identification of self versus non-self, and they work similarly, as we have discussed. And this is the key issue, these regulatory cells, okay? Because if we don't have a method to shut these off, it becomes a really significant problem. So inhibitory ones, we want things like IL-10 to slow down inflammatory response. Or this thing called transforming growth factor. And again, you might remember the other one I took, and you can see it there, it's called tumor necrosis factor. And that's been around for a very long time. That one it's sort of a universal go-to, with particularly psoriasis and psoriatic arthritis are not the same thing. They sometimes have certain similarities, particularly with the rashes associated in certain areas. But psoriatic arthritis very often is treated with these basically not the tumor growth factor, but not the transforming growth factor, but the tumor necrosis factor. And so we're able to utilize that, make that artificial. The problem is, and that's my other one I took, that if you want to think of the way what's working with it, you're basically you create certain problems. So if you're going to block the inflammatory effect of tumor necrosis factor, which is sort of the underlying cause of that arthritis, you're more prone to tumors. So not only was I taking it without a history of any kind of significant other than the bladder cancer, which is a different mechanism. My first wife had very famous, I'm sure I told you about it, neurofibromatosis, elephant man disease, in a very relatively mild presentation where it showed up on her skin. She made tiny little nerve and fibrous tumors, and but she was prone to making nerve and fibrous tumors anywhere. Because of that, she ended up with something the size of a softball in her abdomen. They thought it was a lymphoma. It was it was a benign neurofibroma pushing against the underside of her pancreas when they extirpated it surgically. She ended up with horrible pancreatitis. I mean, pouring out into it was awful. I've never seen anybody such pain. It's terrible. So understand it's really it's the only reason I'm not. One does not brag about a sordid health history, but it should be very informative for students that this can happen to anybody. And it's not like and she never smoked or drank. This is a hereditary condition. Mine were unadvisable lifestyle choices. And this is a nice little summary. We did that. Look at the animation, and here are the graphs. So most common from, I usually make jokes about who would be from a different species, but let's not do it. Allograft is from the same species. So, and we tissue type them based on the MHC antigens, based on the ABO blood system, other blood antigens. The closer the match, theoretically, the less the immunological phenomena that's there. Immunosuppressives, a lot of side effects. It's gotten better over time, not as bad as you think. And this is what happens when you elect to suppress your immune system. You're more likely to get bacterial and viral. So the leading cause of death among transplant recipients, when this was done, this is about 8 years ago. If you want to think of the age of this particular PowerPoint sequence, 10 years with a 50% success rate. It's gotten better. For years, we've started to see people would have a 3 to 5 year on a new heart. I mean, it's great. They have it now much longer with the improvement of these things. Kidneys last for a particularly long period of time. You don't have to have typically the replacements, if you're fortunate, maybe get done in your, as you approach your senior years, 50s and 60s, and might last the duration with anticipated lifetime. Just all sorts of stuff about this. And we're fortunate here, and hopefully not you, but anybody in your orbit, this is transplant central right here. All the other places in the country that learned about it mostly from Starzl Institute here in Pittsburgh. I mean, it really put a stamp on this particular area. My previous nephrologist, my previous urologist was a transplant urologist. Same group, but I went to, because I ended up going to the guy who was the cancer guy, who runs, if you end up doing anything touring over at Allegheny General, he runs the urology residency now. Give him a hard time. Right now, if the Penguins make it, he's growing his Stanley Cup beard. He keeps telling me, wondering why I don't retire. I keep wondering why he doesn't retire. Immune problems, yes. First, we'll start with immunodeficiencies. They are less common than you think. You can have them, and this is very famous, okay? Congenital or acquired. Well, congenital used to be called SCID, severe combined immunodeficiency syndrome, deficits in B and T cells, a particular enzyme, blah, 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 blah. Now we can treat these with bone marrow transplants. Before, this was called the bubble boy syndrome. Okay, and so these people were potentially contact with anything, almost any foreign antigen, potentially could kill them. So basically, they had to live their life in a bubble with only getting no person-to-person interactions. Very early in his acting career, John Travolta portrayed that because it was like a book about this. But they didn't have that therapy. And Seinfeld did a very, very funny sketch about you, very dedicated to this, just saying, in a highly irreverent manner. There was a TV show from the 90s, Seinfeld. Hodgkin disease is acquired. These can be viral and typically are, okay? And there's Hodgkin's and non-Hodgkin's lymphomas. It may sound like a terrible thing, but again, when they did that workup on my wife, and I said to the lady who was doing the operating over at St. Margaret's, I said, "What do you think?" She goes, "Well, if we're lucky, it's a lymphoma." Huh? It's cancer. He goes, "Yeah, but they're treatable." And many of you, hopefully, haven't been touched by it, but treatable is a very good word. Not a lot of things are curable in this day and age. Things that are treatable are good words. Because if you have an avenue for treatment, people can function and function for a long time. They can be treatable for the duration. She was fortunate it turned out not to be cancerous, despite the post-operative problem that occurred that was just almost unavoidable based on where it was. And very famously, although this is one of the times we look at it as AIDS. Again, HIV, the immunodeficiency virus, it targets the one cell we can't do without, the helper T cell. And effectively, it becomes when it's invaded, it becomes a little factory that starts to release viruses, and it invades other helper T cells. And eventually, that population declines because they no longer measure as functional helper T cells. Once it falls below a critical level, or there's some other sign, at that point, the transition from HIV positive, which is not fatal and treatable, which it is, and will not shorten your lifespan, which is what fatal means, then it becomes fatal, and we now call it AIDS, acquired immune deficiency syndrome. And there's a lot of AIDS-defining illnesses. Somebody who's HIV positive gets tuberculosis, gets a deep fungal infection, gets Kaposi sarcoma. There's a laundry list. You can look it up. I don't want to give you the whole spiel about it, but the fact that the problem is we don't have any reliable way of understanding when we have been exposed to HIV. Unless we know we had blood, you have to have an index of suspicion. If you have in the workplace have gotten a body, some kind of fluid splash, you need to report that and get that checked. If you have, and I am not judgmental about your lifestyles. Do whatever you want. An element of caution is advisable. But if you're having unprotected intercourse with another partner, at the very least, you got to. I'm not. I told my own kids the same thing. I find in life it's a very famous saying that I made up. The only behavior you can control is your own. So I can't tell my kids not to do something. Oh, I wish I could, but the reality is you need to be responsible in doing that, and doing that means to get checked. An isolated exposure to someone with HIV who's HIV positive is not going to necessarily affect you. Because being HIV positive means they have had the antibodies. It does not mean that they're actively in their bloodstream or secretions or genital secretions or whatever. It does not. That's all about something called their viral set point. And really, if they are responsible, they engage and they go, my viral set point is this, we should be all right using some type of appropriate measure. Because it was terrible. We used to shun these folks. We didn't know how it spread. Oh my God. Don't come near me. People didn't know. People were stupid. But I understand, scared is a better way. And it was diagnosed by a fungal pneumonia called pneumocystic pneumonia. It has a different name now. We learn about it, micro. I don't think, depending on where you're going, if you need more information, let me know. I'll flip you my micro lecture when I do the micro, because you don't get a lot of this stuff. We may talk about it a little when we do repro. Okay? HIV, all sorts of things, all sorts of secretions. The problem is it has to have a barrier damaged. If you have a barrier that has been damaged, it gets through. Normally, that is not the case. Someone with a pre-existing condition, someone with a herpetic lesion, some kind of sore, cold sore, or genital cold sore. That's why male to male, that's why they thought it's some scourge that the Almighty has brought upon people who are gay. Oh my goodness, stop them. Baloney. I was going to say a bad word, but the reality was anal intercourse, male male or male female, tends to that particular passageway is not designed for that kind of trauma. But as far as I'm going, aren't you glad you came today to hear this? Uh, it's important stuff to know. I don't know, but in my days, my parents were like, "Oh my God, here, read this book." My mom and dad were born before 1920. What are you talking about? We don't talk about that. That's the problem in this country. We don't talk about that stuff at the dinner table. In Europe, they talk about that at the dinner table all the time. It's not. We are trying to think of the word. My dad had a great word for that. It's a real word. We are so immature. It wasn't immature about that. We're such a young country that the concept of doing that. So what do you mean? You can't talk about that. Well, if we talked about it more, in the civilized world, where everyone defined that, is we have a massively higher rate of STDs in other country. Why? We don't talk about that stuff. And kids find out, oh, you can't get pregnant the first time. Hello? Have you seen my daughter, my granddaughter, my great grandson? Say. So all of that stuff. So HIV, 2 to 10 years, immune system collapses. You don't want to even think about it. And so they're all, and we're not going to get into the virus and the reverse transcriptase now. Don't need to. Okay, lots of antivirals, and now typically the cocktail is 4 of them. Did you do antivirals when you guys were in micro with Dr. Maurer? Analogs, nucleoside analogs, reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors. You talked about that? Good. I mean, I'm just telling you. So autoimmune diseases, this is really, and I don't want to step on anybody's toes, so to speak. When the immune system loses its way, it can't figure out, for whatever reason, it all of a sudden thinks something in you is foreign for some reason. And it may just be foreign. So autoimmunity, production of autoantibodies and sensitized cytotoxic or killer T cells that destroy body tissues. And we classify it based on this. To wit, these are all bound to be, these are all now pretty much accepted unanimously as autoimmune disorders. When I started the studies, it was a wonderful little book. It's a softback that everybody got called the Primer on Rheumatic Diseases. That was 1976. I wish I still had it. That was one of the best textbooks I ever had. And I got lost in translation over the many years that I've moved. But I mean, these were presumed were rheumatoid and lupus. Other things like MS and myasthenia gravis were possible immune disorders. We didn't know you didn't have fixed criteria. We didn't have great lab tests to do that. We didn't have any of those things to do that. Okay? So rheumatoid arthritis, joints particularly, but it has widespread problems in the body. So your body is, unfortunately, you get nodules in different places, the deformity. So it's more than that. Remember that I was telling you about that when we talked about arthritides, that young girl who's just such a severe presentation of her immune system, barely survives in her 20s. Myasthenia gravis, we talked about. MS, people are maybe talking about that. Graves' disease, they may be talking about that. Diabetes, why? We see antigen antibody complexes in the kidney. They only form because antibodies are clumping with particular antigens in such a way that it can't be broken down satisfactorily, and they plug up the kidneys. That's why type 1, we used to think it was something else. We had this, we call it Kimmel-Style-Wilson disease. Clumps of protein formed in the kidneys along with it and caused high blood pressure with diabetes. The reality was, no. In modern science, when we analyze them, in the age of molecular biology, guess what? Immunological complexes. Lupus, very interesting. And I mean, someone will be presenting about lupus. Glomerulonephritis. And there's a lot. I mean, this is one, my the stepson I had dinner with last night who taught here got this from a sore throat. This is one of the complications of streptococcus. Streptococcal, a sore throat, or streptococcal skin disease called impetigo, they can shut your kidneys right down. What happens is that phenomenon. The antibodies and the bacteria particle form these complexes, and your kidney has one response. We didn't do kidney yet. When it gets clogged, when it gets damaged, when there's bleeding, when it's hurt, it shuts down. Not enough blood flow, it shuts down. And he had this. He was a junior in high school. We were all together, went to the doctor, and he goes, no skin problems. He goes, what happened? About 3 weeks, I had a pretty bad sore throat, strep. Bing, check, please. I mean, he was hard. He wasn't going at all. And he had like a band concert down in Florida with Seneca Valley after that. But he managed to make it. So the trouble is we're trying to suppress it. For years, the treatment was corticosteroids. I periodically take a corticosteroid shot. I don't really care. It's not as scientific. It works. And I don't want to take those other biologicals. It stops the cytokines, blocks co-stimulatory molecules. It's basically it stabilizes membranes, and these structures are not released. So I mean, these are the type of things that we can get. So I took the ones that address cytokines and address the interleukins. But I mean, I found this to be the easiest. And I mean, I've given enough shots to people over the years. I gave myself one, last week. Last about a month and a half. So we're trying to, those regulatory, we used to call suppressor T cells, make more of them, more self-tolerance with vaccines. We do all sorts of things that are in there. And so why it occurs, foreign antigens that resemble self-antigens, antibodies against foreign antigen may cross-react. That's what happens with streptococcus and something called rheumatic fever. It's a look-alike phenomenon with a small percentage of Streptococcus pyogenes, the strep throat strep. If it's not treated appropriately or at all, it forms antibodies that attack the lining cells in your joints, hence rheumatic, and your heart. It's heart valves. Very dangerous. Okay. And so these are other things. Mutations can occur. That occur changes in self-antigens by haptens, like allergens, release of new ones. I mean, there's all sorts of stuff that can happen. And rather than go crazy going this is really the last topic for this. We'll surely finish this Friday, but I'll give you an idea. We talk about these things called hypersensitivities, immune responses to perceived, otherwise harmless threats that cause tissue damage, your basic allergies. Okay, when we talk about an immediate hypersensitivity, what you and I would call an allergy, maybe you're like me, I get spring and fall allergies. Okay, pretty common. So now when the flowers come out, I'll be sneezing every morning. And they go away and the pollen comes out and the ragweed of the fall. Here we go. So their time course and what kind of antibodies, or are they T cells? And now we're going to see we're talking about immediate, subacute, and delayed. The delayed is about T cells. That's where we start talking about the TINE or TB or MANTU, all the tests that we do for tuberculosis. And everybody's had to have one in here, right? They gave you a TB test under your skin. Big article I just read on one of the news sites. They're seeing in the cities, in New York City, a real uptick in tuberculosis. Overcrowding, poor healthcare, limited resources. It's all about overcrowding. Type 1 allergies. Right away. Initial contact could be asymptomatic. Remember, it's just like I showed you before. It's not the first one, it's the next one. It activates IgE, and you end up with problems because they're bound to mast cells and basophils. And a later encounter, not the next, a later encounter. It may never happen. It may happen the next time. It may happen years, decades after. Causes a flood of histamine released from the IgEs, resulting in induced inflammatory response. Vasodilation. We saw when we looked at what happens in immunity. Histamine causes the vessels to dilate, changes in them, that they become leaky. All those symptoms, nose, asthma, if it's inhaled. Antihistamines work. We have good ones today because they don't make you drowsy, like Zyrtec, that category. And they can be local or systemic. And again, mast cells of the skin, respiratory, and certainly gastro. So we have, when you hear about food allergies, they're real. They're not, they are, thankfully, the foodie world, the restaurant world, and the food industry is much more sensitive today. If you go to a good quality, they're all going to tell you, is it gluten free? Is it this? Is it that? Is it vegan? Is it vegetarian? Does it kill milk? Tree nuts? The whole game. And I repeat, do not be afraid to ask them specifically. But I forget why we were asking, because for one of the kids who was vegan, it struck me as everything here was just fine. And then all of a sudden, is this a vegan burger that was on the menu? And they said, yes, everything but the roll. Because they happened to use a brioche roll, which had egg in it. People who enjoy brioche. It's French. So, they're going to tell you because they don't want to have somebody all of a sudden getting super sick from something they ate there in front of a crowded restaurant. Oh. So the worst one of these is this, anaphylactic shock. Now we used to use the term anaphylaxis differently. Now they're used interchangeably, mostly injected, typical bee stings. Everybody knows somebody probably carries an EpiPen. It's not just that. Nut oils are a big problem. I don't care where you go. You look on it, you got to read the back of the label to make sure it wasn't in a place that uses things like dairy or nut oil. If it is, you got to find another, make it yourself, or find a place, and you can find it on Amazon. You can find anything on Amazon where you're going to be certified to be free of those things. Those will kill you fast. My wife's oldest, we don't have a lot of contact with him. Married to a witch. Real. He has a farm. He doesn't carry an EpiPen. There are bees all over the place. For a smart guy, that's pretty dumb. Okay. And what happens? You remembered this. What that does is bronchioles constrict. Okay. So remember those beta 2s and stuff like this? It's a whole lot different. It has a reverse. When you get histamine in and around bronchioles, they constrict. That's why we use that beta 2 stimulator, the ventilators and things like that. So vasodilation, low blood, and that's why it's shock. Hence the name anaphylactic shock. Anything that lowers your blood volume, the vessels expand, fluid leaks out, the vascular system collapses. So initially the treatment is epinephrine. Years ago, it was much more difficult. Now the EpiPen has been a big plus. What happens in the emergency room, you get them in time, it's not a problem. But the EpiPen has made a whole difference. It was just overpriced. And they show you this, and we're just about done. and the areas that it can affect. We'll leave it there. We'll finish these other hypersensitivities. Be done with this chapter. Probably get started here on blood pressure dynamics next. Thank you. See you soon.